All right, today we have Dr. Tara Heagele. She is an assistant professor at the City University of New York's Hunter College School of Nursing in New York. Dr. Heagele started her program of research by exploring the household emergency preparedness activities of elderly and medically frail community members, qualitatively with the hope of better understanding the reasons why people do or do not prepare for disasters to inform policy. She is especially interested in the role that nurses have in mobilizing the community to prepare for and recover from disasters. She hopes that her disaster nursing research will ultimately save lives and promote disaster-related community resilience. In this presentation, Dr. Heagele will discuss the evolution of her program of research, describing the findings from 3 of her studies and providing implications for practice. I just want to let everyone know that we will have a Q&A session at the end. So if you could just put your comments and questions in the chat, we'll get to those at the end. And then in terms of continuing education credit, I will send up a follow-up email after the webinar today with a link to the recording as well as the evaluation and post-tests. We are still doing those post-tests. We're grading them manually right now. So give me about 2 to 3 days to make sure to get your certificate to you. We are rolling out a new education platform at Annie we're really excited about. That should be up and running in a couple weeks to a month. So after this webinar, hopefully the next one you attend, we'll all go through that automatic grading process and you'll receive your certificate right away. I will hand it over to you, Dr. Heagele.
Thank you so much. Thank you everyone for having me. I'm just going to share my screen. Okay. And I will get started. So here's today's objectives. I also hope that you'll be better able to protect yourself, your family, and your home after this presentation. And I hope that you'll serve as a trusted risk communicator about the importance of disaster preparedness to your community members. Here's a little bit of background about me. How did I get into disaster nursing research? As a child, I lived through several natural disaster events. And I joined my local first aid squad at 14 years old, became an EMT at 16, and just kind of witnessed many life-threatening events because of medically frail community members not being prepared for disasters. Working as an ER nurse, critical care transport nurse, since 1999, I have either volunteered or worked through every local disaster during that time as either an EMT first, then a nurse, and kind of shouldered the burden of unprepared community members during disasters. I and my coworkers put ourselves at risk, rescuing people during dangerous situations. And I remember working through storms, hospital being on generator power, and having this influx of patients coming in and thinking to myself, what, wouldn't you rather be at home, like under a blanket with your flashlight and your cat? Why are you here? Why are you in this ER? Why couldn't you be prepared? So I started my research journey from a feeling of frustration, right? But as soon as I started actually doing research from the very, very start, that feeling of frustration quickly transitioned into understanding. There's so many barriers that people have to becoming prepared adequately. And now it's making my life goal to help nurses help those in our communities and our patients be better prepared. So, all right, pictures throughout my presentation feature my home disaster preparedness kit and the commercial disaster kit that I use for my intervention studies. I put the contents into the captions. I'm not going to talk about the pictures, but it's going to be there for you to see. But I have no commercial interest in these companies. I'm not being sponsored by them. I'm not endorsing the projects. I actually just chose to buy these things for myself, have used them, and I'm enjoying them. So I'm going to show you what I've got. In fact, I actually spend most money, they're getting money from me. I'm not being paid at all, if that makes sense. So look, all of this fits in that one container from the previous slide. I can grab that container in a precipitous evacuation and get in my car and drive off. I also have a go bag in my car that has clothing and toiletries. This type of Tupperware container here, it would be difficult for somebody with mobility deficits or strength issues. So you can get tubs that are on wheels. And then there's a bucket I showed previously. So before we learn how we can help our community members get prepared for disasters, let's do a case study about preparedness using you all, the audience, as the case. So first, think to yourself, do you have a home survival kit like I do? And if not, here's a household emergency preparedness questionnaire that I developed with an amazing disaster nurse researcher team. More on this later on in the presentation. I can't spend too much time on this because this is a shorter presentation. If you want, you can screenshot this and do your own calculations and score after the presentation. Also, anyone can email me and I can give you a copy of this instrument. But if we were doing this right now, if I were to sit here and read every single question, you would give yourself 1 point for every preparedness action yes answer. And then you'd give yourself 0 points for any no's. And you would keep track of your points. So these are the preparedness actions. Here, you would give yourself 1 point for every communication plan yes answer and 0 points for the no's. You would add those points to the first slide, now to the second slide. On this one, you'd give yourself 1 point for every evacuation plan answer that was yes, and then keep track of your points, add that to the first 2 slides. By the way, this is a big hint for the post-test. Even if you feel very well prepared for a disaster and you're able to safely shelter in place with your disaster kit items, it is not okay for you to ignore a mandatory evacuation order. Got it? So if your home is in a mandatory evacuation zone, you've got to get out, even if you feel like you've got all of your supplies and whatnot. And then here's disaster kit item answers. So for every disaster kit item you would give yourself a yes and add that to the points of the previous slides. So you should have 42 points to be considered prepared for a disaster. However, not everything is applicable to all respondents. Like if you don't have a baby, if you don't have pets, then some of these are NAs. So I will say that anyone who has 31 points or higher could be considered prepared for a disaster according to this instrument. Now, I can almost guarantee that most of you were not prepared as well as you could be. You've got some stuff taken care of, but not everything, and that's extremely common. So doing some self-reflection, we as nurses presumably have good jobs, right? And we also have disaster preparedness knowledge and education, and yet we aren't very prepared for disasters ourselves. So how can we expect our elderly and medically frail community members to be prepared? So the background of my program of research is obviously there's a growing frequency of extreme weather events, man-made disasters, and humanitarian crises. And the greater part of the population, like I just said, under study, vulnerable or not, no matter their demographic characteristics or geographic location, is unprepared for a disaster. And I found when I was trying to do my dissertation that for those of you who are going to go for your PhD, you have to defend every single decision that you make to do this research. I found that I couldn't find a single accepted definition of preparedness. There's so many checklists out there. There's so many organizations that have different things that they put out that means to be prepared. And I also couldn't find a gold standard instrument to measure disaster preparedness. So I know household emergency preparedness is a public health concern, and lack of preparedness, especially in medically frail populations, consumes responders' time and can easily deplete community health resources. And increased levels of household emergency preparedness could save lives. It could prevent worsening of chronic medical conditions, and it could decrease the likelihood of responders having to brave dangerous situations to assist those in need. However, this is a big deal. Literature is actually lacking to support the claims that having a disaster supply kit actually results in self-sufficiency and contributes to disaster-related resilience. So that's a big deal. Anecdotally, we know that being prepared for a disaster will likely have you be able to stay safe, not get sick or injured or even die. But there's not a big experimental study out there that actually demonstrates that. Disasters are always inclusive, so they don't care about class, race, gender, anything like that. But response and recovery are not inclusive unless we plan for it. So community members with access and functional needs have special needs that should be accounted for during disaster preparedness, response, and recovery. So these are the folks that FEMA describes as having access and functional needs in disasters. Anyone who is elderly, that's defined as greater than 65 years of age, and anyone who's medically frail, people with serious and complex medical conditions, and those with physical and or mental disabilities that significantly impair their ability to perform one or more activities of daily living. And obviously, the elderly are frequently also medically frail. The scope of the problem is the entire population is aging, and then medical services are being delivered in the community more and more. So these statistics from 2018, there's 54.5 million medically frail individuals living in the community. This is the United States data. 47.5 million people with disabilities that might not be able to take protective measures for a disaster, and 133 million people with a chronic illness that could be exacerbated by disaster conditions. Then we've got more people developing and living in coastal areas, and we've got an increased frequency of hurricanes on the East Coast. It's grown by 40% since 1995. And then worldwide, there is a growing frequency of extreme weather events, man-made disasters, and humanitarian crises. So morbidity and mortality outcomes for elderly and medically frail community members are disproportionate to the rest of the population. They are getting sick, injured, and dying more often than the general population. And not addressing these vulnerabilities has been shown to have negative effects on both the response and on the community as a whole. These guys are less likely to recover economically from the expenses related to disasters. It makes an already vulnerable population impoverished. And then the medical needs of the elderly and the medically frail exacerbated by the disaster becomes a severe strain on already stretched disaster resources. So it's important for nurses to understand what makes these individuals vulnerable in order to address those vulnerabilities during preparedness phases of emergency planning. But you as a nurse can participate in all aspects of disasters, from preparedness to mitigation to response and to recovery. So the purpose of my first study, my dissertation study, was to understand how older and or medically frail adults have experienced disaster and how this experience impacts what they do now to prepare for disasters. And my goal was to generate theory regarding the process through which community members prepare for disasters. It actually had to be a qualitative study, like I said, because I could not find an instrument to use. I can share all the publications that I have cited, and all of them go into much, much more detail than what I can provide on the slides alone. I'll send those over to Hannah too for distribution. So this particular part of the presentation is focused on the barriers and facilitators to individual and household level preparedness. Spoiler alert, the only participants in my study that I found to actually be prepared for a disaster were a few seniors that had actually gone to a class at the local senior center called STORM. STORM stands for Seniors Taking on Readiness Measures. It was a class offered by emergency management personnel. The people came to the class, they learned about which disasters affected in the community, how to do an evacuation and communication plan. They were given a booklet to fill out. It was homework. So they had to fill out exactly what I just said: evacuation, communication plans, their past medical history, all the utility company phone numbers, all of the insurance policy numbers and insurance phone numbers. And the booklet has a bunch more information on it as well. But if they did their homework, they brought that back to the second day of class, they got a free disaster supply kit. And these were the only guys that were actually prepared for a disaster. So another side note, with the volume of data that I analyzed for my dissertation study, I was able to get several publications out of my dissertation And like I said, they're all cited. So if you're interested in any more details, just ask. So here's my data sources. I had 33 knowing participants. Those were Hurricane Sandy survivors living in the city of Long Branch, New Jersey. It's where I grew up. For qualitative studies, you want saturation. That's when you know you can stop collecting data. So saturation of disaster experience and motivation for preparedness actions and community interventions was achieved at 26 participants. But because I don't know how to stop, I had to keep interviewing because I wanted to make sure I wasn't going to miss anything. I also wanted more information on my participants' preferred information sources. I then did a bunch of memos. I took a bunch of field notes. I included tons and tons of peer-reviewed research and journal articles, emergency management textbooks I read, newspaper articles. I analyzed 143 newspaper articles published in the days leading up to the storms. That was Hurricane Irene in 2011, Sandy in 2012, Joaquin in 2015, Matthew in 2016, and Hermine in 2016. And then I also looked at what was published in the days leading up to a winter storm called Stella, and that was in 2017. I watched television broadcasts on disaster preparedness and analyzed that. I watched documentaries like on Katrina and other previous storms. And the purpose of collecting all of this non-interview data was to perform discourse analysis on what is disseminated about natural disasters with a focus on household emergency preparedness recommendations. And the discourse that I found was that people should take responsibility of their own preparedness. But again, that I also found that that's not really a fair expectation for many community members. Here's just some more of my data sources. I looked at preparedness educational resources like internet postings, brochures and pamphlets, posters, swag. I looked at disaster preparedness reports from senior advocacy groups like AARP and Help Age International. I attended 2 emergency preparedness conferences in Atlantic City, New Jersey. If you like disaster preparedness, come on down to Atlantic City. It's a good time. I also attended a massive community festival called Ocean Fest. It's held in the community where I did my data collection. There's over 100,000 attendees every 4th of July for this, a very heavy emergency management presence. They even have a mobile, like a trailer that they all hang out in. There's ambulances from all the surrounding communities posted. So I wanted to see if they were disseminating anything about disaster preparedness, because there's a lot of community organizations that have tents and whatnot at this festival, and there was nothing disseminated. And then I also looked at books, coffee table books on past storms. I read some nonfiction memoirs about survivors of past storms. I even analyzed a cookbook, which I have a picture of later on. It's called The Storm Gourmet, and it's a cookbook of recipes that utilize non-perishable foods that don't require a heat source. I looked at the city's emergency management plans. I looked at public policy, like the Post-Katrina Emergency Management Reform Act. I analyzed the flood maps of the city, and I then also interviewed the city's emergency manager, and I interviewed home care nurses in that community to see what is done about disaster preparedness. And the findings, how have the medically frail adults experienced disaster? So here's my core category. Here's the other findings that I found: the causal conditions, the strategies taken in response to causal conditions, and the facilitators and impediments to those strategies, and the consequences. But I found that coastal, urban, elderly, and medically frail community members are generally considered unprepared for a disaster according to FEMA standards. This is due in large part to actually a lack of education on how best to prepare. Once they are educated, I saw motivation for self-responsibility of household emergency preparedness. But community interventions like distributing those disaster supply kits and offering evacuation assistance help overcome any situational impediments to preparedness, and they provide the best chance for these vulnerable community members to survive the disasters. And if my participants were incidentally prepared, not purposely, it was largely due to their past experience with a disaster or their professional experience. I had a few participants who had worked in schools in their younger days, and they had set up storm shelters in the schools, and so they kind of knew what should be in their home in the event of a disaster. And here's the vulnerability to hazards. Blue font is the physical pathways to health vulnerabilities, and purple font is the social pathways. So for advanced age, these folks are less tolerant of temperature extremes due to circulatory problems, loss of subcutaneous tissue and sweat glands. They have reduced ability to perceive heat. They have delayed thirst and perspiration mechanisms, and many take medications that can influence body temperature regulation. For number 2, chronic diseases, the ones that are most associated with increased morbidity and mortality during disasters is diabetes, folks with strokes, heart attacks, chronic lung conditions, hereditary blood disorders like sickle cell, anyone with end-stage renal disease on dialysis, people with high blood pressure, people with arthritis, people with dementia. And this is because they're experiencing disruptions in their routine medical care, including difficulty with gaining access to their care providers and their healthcare facilities. 3, dependence on others or objects. People with that need assistance with their activities of daily living, like bathing, dressing, grooming, or using the toilet. If they're getting meals on wheels, if they have a home health aide, if they're relying on electricity for any kind of medical devices, they're relying on supplemental oxygen, if they rely on refrigeration for medications like insulin, all of those folks experience increased morbidity and mortality in disasters. Number 4, for mobility deficits, it's difficult for people with mobility deficits to evacuate quickly or even take cover. Say it's an earthquake situation. Somebody's utilizing a walker, an earthquake happens, all of the pictographs that are distributed usually feature people dropping to the ground and crawling under a table and holding on. Well, they're not going to do that. So more recently now I'm seeing people on wheelchairs in these posters, and it says lock the wheelchair and cover your head. But if you're helping these folks to evacuate and you tell them that they can't bring their wheelchair or their walker or their cane with them, they're no longer going to be self-sufficient wherever they are evacuated to. For number 5, memory disorders, dementia, delayed reaction times, and psychological distress, all of that occurs during the disaster situation, makes folks more vulnerable. For 6 is sensory deficits. They have inability to see, hear, taste, or smell. They're unable to see warning signs, hear emergency instructions and alerts. They can't navigate in unfamiliar environments. And actually, these folks are more likely to eat spoiled food. It's been sitting around for a few days. They don't smell that it's rotten. Taste buds are impaired. For number 7, lack of social support. So people that do have good social support, they're going to receive assistance from their family, their friends, other community members in obtaining disaster information and evacuating and sheltering, getting food, getting to their healthcare, and rebuilding in disaster situations. But housebound individuals and socially isolated individuals, they're less likely to receive any of that, and they can even be rendered invisible to responders. People with low socioeconomic status, if you're on a fixed income, as in a retirement situation, you have poor credit worthiness now. There's little room to afford supplies, fuel, food, lodging related to evacuation. You can't afford to make protective home improvements or rebuild post-disaster. For 9, high-risk geographical location, isolated areas, you're at higher risk for morbidity and mortality. Also urban areas, flood-prone areas. Any place that contains poorly developed physical infrastructure, or maybe it's crumbling infrastructure. All of this, places that have a high concentration of poverty or limited access to social services, all of that can increase the morbidity and mortality. For number 10, low education level, and 11, native language speaking ability. Both of these categories, the people experience difficulty or inability to access quality information resources. For 12, female gender, it's because we happen to live longer on average, so it makes it more likely that we're living in poverty and inadequate housing. Also, there's cultural prohibitions. Older women may be less likely to evacuate to storm shelters that don't separate individuals by gender. Now, going to those shelter conditions, anyone watched how Hurricane Katrina unfolded? Would you want to go to a shelter? I mean, that's kind of implanted in everyone's memories. But in addition to that, many shelters lack ramps, maybe railings, lack health services, medications, medical equipment, have inaccessible toilets, inadequate lighting. There could be poor bedding. imagine our 80 and 90-year-olds crawling down onto a cot and laying on a cot scenario. There could be inappropriate food. It's excessively noisy, and it promotes separation from family support. So many will stay home instead of enduring shelter conditions. For 14, the older people tending to live in older homes of low structural quality, and they have no means to make those storm resilient improvements. And then past experience with disaster can go both ways. If you've survived a previous disaster with minimal negative impacts, you may underestimate the consequences of future disasters and not take appropriate protective actions. And if on the other side, if you've not recovered from a previous recent disaster, then you're even more susceptible to disasters. So other facilitators are that people have to identify that they're actually at risk for disaster. They have to have that knowledge. They have to perceive that they're highly vulnerable to that risk, and that they have self-efficacy to do things to overcome their vulnerabilities, so long as it's low cost in self-protection. So again, giving those disaster supply kits in a brief 30-minute class is a really good way to overcome the self-efficacy stuff. And then I also found that caregiving responsibilities for children, family members, and pets also facilitated people becoming prepared for disasters. Other things, communication infrastructure. We need the community, from the radio to the television to the internet, local leaders. Everyone's got to deliver a clear, concise, timely, and accurate message. And they've all got to be saying the same thing about the threat and the appropriate response in a manner that people of all ages, literacy levels, and native language speaking abilities receive that message. And like I said, it comes through formal venues, informal venues. It could be from other community members, but it's got to be from a trusted source to facilitate coordination, cooperation, and adherence to recommendations and directives. That's where we come in. Who's the number one most trusted profession? We are nurses. So healthcare providers in all care settings, especially nurses, need to educate patients and their families on household emergency preparedness and the consequences of lack of preparedness. More about effective risk communication. It's got to happen throughout all stages of the disaster. Told you it's got to be unambiguous, concise, and redundant. Redundant in this case is a good thing. If you put on the TV and they tell you to do one thing, and then you listen to the radio and they tell you something else, now we don't know who to trust and we don't know which direction to go. And we're going to be less likely to make disaster preparations. We want to take into account any kind of potential visual, auditory, or cognitive impairments. So if you are educating your patients about disaster preparedness, make sure you're using large font and non-glare paper. Auditory alert sounds, they've got to be broadcast at frequencies that older adults with hearing loss can perceive them. Then we want to educate them. And we want to do education in school. Where I work, New York City, they have a disaster campaign for the school called Ready Girl. She's a superhero and she goes and teaches the classes about disaster preparedness. One of these days, I'm going to get around to measuring effectiveness of that intervention so that we can expand it over the whole country. But I've got too much on my plate at the moment. If one of you guys want to do that research study, please do. Animal networks. So service pet associations, veterinarian offices, rabies clinics, all of those places can distribute disaster preparedness information for both the pets and the family. We've got water and power companies. Healthcare providers, let's go there. We are just started to include the predictor variable of, did your healthcare provider talk to you about disaster preparedness in our recent studies? And those who had a discussion with their healthcare provider were some of the best prepared study participants. So we want you guys to talk to them about it. The water and power companies can put out information about disaster preparedness. And also we have to foster social support. We want to always have messaging of check on your neighbors. Here's some free resources that I've used in my disaster research. One's for New York City, one is for New Jersey. These are the booklets that I talked about that were given out during the storm program. And like I said, it has your communication plans, your evacuation plans, the utilities information, tips for disaster preparedness. What's the difference between a watch and a warning? How do you evacuate? How do you know you're in a flood zone? All of that stuff, even disaster supply kit checklists. Both of these resources are free to download. New York City will actually send you booklets, paper copies of them if you want them. but that both of them are also individualized to these communities. So something might exist like this in your community. You just have to look for it. I know with these two, the New York booklet comes in, I want to say 13 different languages. And I think the New Jersey one comes in also different languages. Just type into Google the titles and you can find them pretty easily. So going back to that, if you need to make one, if something like this doesn't exist in your community already, you need to make it, you've got your inspiration right here. And then the Fema checklist. This is on ready.gov. It's just the supplies. In the paragraph section, it's got a ditty about communication and evacuation plans, but it's short and sweet. And this one comes in, if I remember correctly, 32 different languages. So you can use this in your education as well. All right, so another facilitator of disaster resilience is evacuation assistance. You want to evacuate them in advance, obviously. Evacuate with their assistive devices, provide the transportation to the storm shelter, provide that storm shelter. And of course, please evacuate pets. Separating an owner from his or her pet can produce the same grief reaction as the death of a family member. So evacuation of pets has to be considered in storm shelters. If pets are not evacuated, owners may risk their lives by either not evacuating at all or returning too soon to the disaster site to find their pets. Medication and healthcare. So medical needs shelters. I'm not sure if all nurses are aware of these. I actually was not aware of it until I started my research. Medical needs shelters are special storm shelters for people with medical needs. They've got to be made mandatory and in each community, at least one per county even. And it's got to be open before the disaster. I see this because in Hurricane Sandy in the New Jersey area, the medical needs shelters were open after the disaster. And they were opened in inconvenient places, too far from people's homes. They didn't have adequate staffing in there. So you want to open them up before the disaster, staff them with nurses, public health department personnel, patient care techs, shelter staff, paramedics, respiratory therapists, mental health staff, and pharmacists. And that's where people who would just not be okay in a normal storm shelter can go. Say you just had surgery, right? You get discharged home and then a hurricane starts coming a few days later. Being in a storm shelter for the general population is not ideal for you. So you go to the medical needs shelter. Anyone with chronic conditions, anyone that needs that refrigeration for their meds, all of those people go to the medical needs shelter. And then we need the medications for chronic illnesses in the stockpile. Most of our medication needs post-disaster are for chronic conditions. So before the disaster hits, we need to form partnerships with medication manufacturers, medication distribution agents, and retail pharmacies to ensure that we've got our medication needs met during the disaster. Okay, so implications for practice. We want equitable distribution of supplies. Meals that are distributed to non-responders should be heart healthy and low sodium. The meals ready to eat that you see in the military, that's not appropriate for people with chronic illnesses, way too high in glucose and calories. So we want to have heart healthy, low sodium meals. And when distributing these meals or any of the disaster relief supplies, the elderly and the medically frail may not be able to tolerate standing in long lines. So we should have a fast track queue designated for these folks. I was cringing during when the COVID vaccinations first started. Do you guys remember seeing those long lines in Florida of elderly folks they're standing and with walkers and whatnot? I'm like, somebody's got to get this moving quicker. So I'm glad that they started putting people in cars through lines after that. So we're learning from each disaster, right? We also need psychological care post-disaster. So the stress of the event could elevate blood pressure, cause confusion, alter blood glucose control, exacerbate chronic illnesses. And there's psychosocial interventions that can be implemented, such as grief counseling. All of that's got to be planned for and made available. And then aid individuals in obtaining governmental assistance. A lot of our governmental assistance applications are online, and some of the older generations not able to navigate that. So we're going to assist them. So the elderly and medically frail can also be assets in disasters. They should not be just viewed as helpless and vulnerable. They can also be our trusted messengers for risk communication. They have advice and experience from past disasters. They can instill hope for the future. They tell people we've experienced this before. We recovered, everything's going to be okay. They also, and I found this in my study as well, they look after supplies. A few of my guys were volunteers in the disaster relief distribution centers. So they can look after supplies, help distribute meals. They can care or look over the sick and injured, orphans, children, and other dependents. And a lot of them have traditional survival skills. So utilizing and protecting the elderly and medically frail before, during, and after disaster will enhance community resilience overall. So that brings me now to the second study, the Household Emergency Preparedness Instrument Study, also known as the HEPI. Now, after I did my dissertation study and it was qualitative, I knew that I needed an instrument to use for the rest of my program of research. And the whole disaster, public health, and nursing community needed an instrument as well. So here's where this started. The HEPI assesses whether specific preparedness actions have been taken and the presence or absence of essential supplies that would likely that could enable households to safely endure conditions that disasters would likely present. And that's loss of power, limitations on water, lack of access to additional supplies for at least 3 days. Accurate assessment of preparedness levels is critical for effective planning and necessary to enhance health promotion and prevent injuries and provide disaster-related community resilience. This is the HEPI development team here, a group of disaster nurse researcher rock stars. You can reach out to any of us for a copy of our instrument and instructions on how to use it and score it. The purpose of this study was to generate consensus on that concept definition of what does it mean to be prepared for a disaster. We wanted this opinion from experts representing multiple disciplines and countries, along with community stakeholders, to develop an all hazards valid and reliable instrument. The HEPI questions were developed using 3 sources of data to inform consensus. We did a literature search, we used existing instruments to inspire our instrument questions, and we used an international expert panel via the Delphi Technique. For literature search, we identified 52 articles. Only 22 of them had any kind of instrument development information on them, and none of those articles were specifically instrument development publications. This is important because you need to understand how the instrument was developed, if the methods were sound, reasonable, valid. So we wanted to do this for you guys. So for the researchers that did create their own instruments, and there was a lot of them, the Fema recommendations for what it means to be prepared for disaster were the most popular to inspire the instrument questions. And after this literature search and review of the evidence, the HEPI creator team agreed that a gold standard household emergency preparedness instrument did not exist. So we went on to using existing instruments. One of the researchers, Dr. McNeil, she had created the Preparedness Index and used it in 2 previous studies. So we used her instrument as the baseline instrument and then kind of took questions from the other instruments that we found. In the Delphi technique, we assembled an instrument for Delphi study participants to evaluate. More on this now. Why the Delphi technique? This is a really, really good study technique when participants don't have a history of adequate communication. We wanted our instrument to be global and all hazards, not, a New Jersey or a North Carolina or South Carolina instrument, or a Texas instrument, because that's where the HEPI developers were from. If you need input from more individuals that can effectively interact in a face-to-face exchange, like if they're all over the world and everyone's in different time zones, this is a good technique to use. Time and cost make frequent group meetings infeasible, and participant anonymity is needed to reduce the effects of dominant individuals, i.e. the bandwagon effect. So the Delphi technique is fast, it's expensive, it's versatile, and you have this ability to condense the opinions of many experts into a few precise statements. People can respond on their own time. It's not a live thing. And like I said, that anonymity allows for participation in a non-adversarial environment. So Delphi studies are commonly completed with under 100 participants. We had more than that, so we did good there. We recruited via email. We said the compensation was free and open access to the instrument, but in reality, everyone has free and open access to our instrument as long as you're not using it commercially. So for education research, you can use it with no cost to you. So we targeted disaster experts, community stakeholders, The age of consent, the highest age of consent worldwide is 21, so they had to be 21 or older. English reading, and we targeted the corresponding authors from the articles in our literature review, our interdisciplinary colleagues with disaster research experience. The World Association of Disaster and Emergency Medicine sent out our recruitment message on our behalf, and we used the snowball sampling technique. For round one, because Delphi studies usually have several rounds of data collection, we assembled an instrument that was 106 questions long. And we asked our participants to rank each question on the HEPI from 1 to 5. 1 was unessential, 2, a little important, 3, neutral, 4, important, 5, essential. And consensus on a HEPI question was considered achieved when 80% of our participants' votes fell within two categories based off that 5-point scale. We also asked our participants, should there be subscales for people who are medically frail, for people who have children or pets? And we asked them just how much food and how much water and how much prescription medications and medical supplies do you need to be considered prepared for disaster? We asked them how they should answer questions about their supplies, like should it be a yes or a no? Should it be I have this in my house versus I have this in my disaster supply kit? And we asked them how the instrument should be scored. And we also included 2 open-ended questions. If a supply kit is named something different in your community, please let us know. So you'll see for one of the disaster kit items that has many different names depending on the country is a cooler, an ice box, a chill bin, an esky, and then the freezer bricks or ice cubes, everything that goes in there has multiple names. Diapers versus nappies, flashlights versus torch. Many things had many items. So we got that from that bit of information. And the other open-ended question was, did we miss any preparedness items or actions? And we, of course, collected demographic data. And here's our results for round one. We had 178 disaster experts and stakeholders. Only 131 of them actually left their email addresses for prospective rounds, though. We had 34 different countries represented. And look at all the different disciplines that were part of this. For results of round one, none of the questions on our HEPI achieved consensus to be discarded, but 35 achieved consensus to move on to the pilot test. The participants said, yes, we should have subscales. They could not decide how much food, water, prescription meds, or medical supplies were needed to be considered prepared for a disaster. And they couldn't decide how respondents should answer questions about their supplies or how the instrument should be scored. So we asked them those questions again for round two, but we eliminated the response option that had the lowest votes in round one. For round two, 6 new questions were added due to the qualitative data in round one. You can see them right there on the slide. And work gloves was the only supply kit item that was added from the qualitative data. 18 questions were edited due to that qualitative data. And in round two, we forced our participants into a binary response now, no more 5-point scale. Now we ask them for each question, is this essential or not? Pick one. And the results of round two, no questions again achieved consensus to be discarded. We had 84 participants respond, 14 more questions achieved consensus to move on to the pilot test. We decided that 1 week of food and water should be good, 2 weeks of meds and medical supplies would be good. And the response options for the supplies should be, I have this kit in my home, I have this item in my disaster supply kit, I do not have this item. And that type of response gets at incidental versus purposeful preparedness. And then the scoring, they said it should be weighted in terms of the importance of the action or item. Round 3 was really to determine how we should score the instrument. We assembled the instrument that would be pilot tested, and we asked our participants to decide which question should be weighted higher with scoring. And we had 79 participants respond. Then the next step was to pilot test and refine this HEPI with a diverse sample, allowing for assessment of usability, reliability, validity, and culture bias of the instrument. So we did a cross-sectional study with a sample of New York City residents during the COVID-19 pandemic. The validity of the new scales was examined using factor analysis, and qualitative and quantitative data analysis was performed on the respondents' experience with taking the HEPI. We asked them to rate their perceived clarity of the HEPI instructions and the questions, the difficulty of the HEPI, and the reasonableness of the length of the HEPI. In addition, we included one open-ended question to inquire about anything the participant would like the researchers to know about the experience of completing the HEPI. And our results they were completed with 284 faculty, staff, and students from the City University of New York. And it was about equal faculty, staff, and students. So 2 categories here. We had an internal consistency reliability, strong, Cronbach's alpha of 0.89. A Cronbach's alpha of 0.80 to 0.89 is considered very good, and greater than 0.90 is excellent. So we were very, very close. And then factor analysis. The key concept of factor analysis is that multiple observed variables, the HEPI questions, have similar patterns of responses because they're all associated with a latent variable, which is not directly measurable, and that would be the level of household emergency preparedness. So for our factor analysis, it revealed 2 dimensions of general preparedness, explaining 35% of the sample variance. With factor analysis, the higher percentage of variance explained indicates a stronger strength of an association between the HEPI questions and the concept of household emergency preparedness. Ideally, our variance explained should be 60% or higher. Ours is only 35%. That's still actually really good for a social science measurement tool. And it can be improved though, and we fully anticipate revisions to this instrument. And we hope that this variance score will improve over time. And who is more prepared? Faculty and staff, folks who are older in age, higher income, and those that had previous disaster experience. But that's like I don't know how to say it. They were more prepared. However, the mean HEPI score was 15 out of 42, and 42 is the highest possible level of being prepared. So nobody was quite prepared, right? And then the respondents accepted the instrument. 92% said that the instructions were really clear. 87% said the questions were extremely clear. 78% said the length was reasonable. And 76% stated that the experience of taking the HEPI was easy. So the respondent burden of the HEPI is low, and also the researcher burden. So it should encourage you to use this. The qualitative data revealed that the HEPI helped respondents learn what it is needed to be prepared. It made them realize that they were unprepared and inspired them to develop a household emergency preparedness plan. So the instrument itself can actually serve as an educational intervention too. I also have to tell you though, it did cause feelings of anxiety. So I don't know if that had to do with, it was deployed literally a week probably after lockdown in New York City, when New York City was the epicenter of the pandemic. All the grocery shelves are wiped out, hardware stores shelves are wiped out, people were horrified. So in the open-ended question, our respondents were saying that it caused anxiety. So to be safe, we're going to say that in our instructions to disclose on the consent form and disclose to your IRB that it can cause feelings of anxiety. It can also cause you to remember bad experiences, disasters in the past. And I've already said that in one of my IRB applications, and they said that's fine, it's still minimal risk to do the HEPI. And then we found that construct, criterion, face, and content validity all support the adequacy of the HEPI to capture essentials of household emergency preparedness. Implications for practice. So how are you going to use this as a nurse? Just know the HEPI is a valid and reliable instrument, and it provides researchers, community planners, a replicable approach to assessment of preparedness levels. So you can use it for policy development, mitigation strategy planning, so that you can decrease disaster-related morbidity and mortality in your communities or in your patient population. You can assess preparedness levels of anyone, but for nurses, we would probably target our vulnerable populations. And then provide evidence to support interventions in addressing health needs of community members following disasters. For researchers, the researchers in the group, the next step to the HEPI, we need a predictive validity study. Remember I said that no studies exist that demonstrate that being prepared for disaster actually results in those wonderful outcomes that we say it does, like decreased morbidity and mortality. So you want to use the HEPI to do a predictive validity study. It's got to be longitudinal. We want to see if we are actually getting folks prepared and if they're surviving and having increased community resilience. We want to do a known groups validity evaluation and also do retest reliability assessments. Researchers, emergency planners, educators, nurses, again, you may use the HEPI for non-commercial purposes without cost under the following conditions. definitely cite us in your publications as the HEPI developers. If it's translated into a language other than English, modified in any way, these changes are disclosed in your publications. And do perform psychometric data analysis on the instrument and provide that to us, because all of that information will inform future modifications of the HEPI. For a copy of the survey and the instructions on how to use and score it, just contact any of us. That brings me to the last study. This is called Nurses Taking on Readiness Measures, also known as NTORM. Sounds a lot like STORM, right? What I talked about earlier in the presentation, seniors taking on readiness measures, taking their intervention that was community-based, taught by emergency managers, and putting it into the hands of nurses. So it's a nurse-driven household emergency preparedness intervention that can be offered in the hospital setting. It could be offered in the home health setting to older adults, individuals with chronic illnesses, caregivers of medically frail patients, and new parents. And it's modeled after that community intervention STORM. And because this intervention uses an all hazards approach, it's possible to replicate nationally. I don't know how he got back. Okay. So the first pilot test of NTORM was done in a hospital in Brooklyn in the newborn nursery and the neonatal intensive care unit. We did it with parents of infants, and it was funded, and we had 2 research assistants. So thank you to both. The aims of the pilot study, we want to expand that reach of NTORM to vulnerable populations. We want to evaluate the effectiveness of NTORM for increasing levels of preparedness, actions, and kits. This NTORM intervention enables households to meet the federal emergency management recommendations for household emergency preparedness, to safely shelter in place and evacuate quickly their supplies if needed. And here is the commercial bucket I got for this intervention study. It can be used as a toilet, especially in New York City. The high rises, when there's power outages, they often lose sewer services. So the bucket could be used as a toilet. And here's just a look of the inside of this commercially available kit. So this is a 4-person kit. It's got food, water, multi-tools, whistles, knives, dust mask, work gloves. It's got a radio, NOAA weather alert radio, light sticks, pretty much everything you need. There's a first aid kit in there as well. And food rations that are not good for people with chronic illnesses, by the way. They're high calorie, nutrient dense, but if you're in a survival situation, they're gonna work. And the methods, here I'm giving you the methods now so that any of you can replicate this in your own populations of interest. You can do the NTORM intervention one-on-one in a class via televisit, however you wanna tailor it, okay? So first you administer the HEPI if you're doing it as a research study. I had to, for the pilot study of NTORM, I had to use the Fema checklist because the HEPI wasn't ready yet. I was doing both studies at the same time. So you're gonna put out a measurement tool, provide the intervention. So nurses educate the participants and provide guidance in the completion of their preparedness plan via a booklet, whatever booklet it works for your community. The participants have to do their homework. They have to fill in their plans and their information. The nurses then check for completion of that booklet, answer any questions. And if the participants did their part of the intervention, the nurse can then provide them with a free disaster supply kit. Then you want to administer the HEPI again to determine the change in level of household emergency preparedness. For the NTORM pilot study, we collected implementation data from the nurses. And this is our results. 68 new parents participated, 3 maternal child nurses. The household emergency preparedness score increased from 14 to 97 pre and post intervention. The barriers, this is from the nurse's side, was the weight of the kit. It's 23 pounds. So in that hospital, the policy was that the new moms could not lift, I think it was more than 10 pounds. So all of them needed somebody else to come with them during discharge. The parents were feeling anxious during this intervention, but of course we did this in the middle of the pandemic when New York City was the epicenter. So again, the parents had to have anxiety about bringing babies home into this pandemic world, and then think about disasters on top of it. That might not be the case in future iterations of this. And then there was follow-up with follow-up was needed with the parents. So the nurses had to go back a couple of times during the hospital stay and say, did you do your booklet yet? Did you do your booklet yet? That being said, the whole nurse's time was only about 5 to 10 minutes going over that booklet. So it didn't actually take very much time at all. The facilitator was the booklet and the disaster kit itself. The nurses said if they didn't have access to those things, they might not have time to do this in their everyday practice. And then the cost was about $112 per participant, which sounds expensive, but if one of these babies had a medical condition that was exacerbated by the disaster scenario and ended up back in the hospital, we have to do a cost benefit analysis of how much does it cost to get people prepared and be able to stay safely sheltered at home or an evacuation site versus a hospital admission due to the disaster. For implications for research, please, please, please pilot test this intervention in any other patient population, different settings. Now also ask, what is the patient's experience of the end-to-end intervention? Are they finding it helpful? Would they want to do that again? And again, use longitudinal studies to determine the association between preparedness level and disaster resilience. Last couple slides. What is the nurse's role? Wait, I want to tell you anything over here. No, I don't. Okay. So nurses as leaders in disaster preparedness and response, a call to action appeared in the Journal of Nursing Scholarship in 2016. And the purpose of that article was to develop a vision for the future of disaster nursing for disaster events or public health emergencies. They also want to develop a national set of disaster nursing competencies and integrate learning opportunities into multiple delivery platforms in schools of nursing and continuing educational opportunities. So I'm doing my part. I'm teaching you guys about disaster nursing through this. I'm also do a disaster nursing elective to my undergrad students at Hunter College. Nurses' role as a professional. You guys have to promote preparedness amongst individuals in your care, in your families, in your communities, and within organizations that you present. Wouldn't it be awesome if we can get people prepared and safely sheltered and avoid that influx of patients that come in during a disaster, right? So definitely promote preparedness and demonstrate a commitment to professional preparedness by participating in disaster planning drills and exercises. Now the nurse's role as a community member, just take you out of your professional role, put you as a community member, a good neighbor, be that trusted messenger, be the good neighbor. So check on your neighbors before the disasters. I'm not telling you to bring them into your home and shelter them. I'm telling you, go to them and say, do you need help bringing a case of water into your house? Do you need a ride to the storm shelter? Check on them after the disaster. Make sure that they're not experiencing temperature extremes in their homes. Participate in those drills. Tricky trays, gifts in general. Whenever I have to donate something to a charity, I always assemble a disaster kit because who wouldn't want a disaster kit, right? And it's good for every kind of gift that you can think of. Church projects, you can assemble disaster kits. Sigma Theta Tau, you can do that. Assemble disaster kits, hand them out to vulnerable community members, Boy Scouts, Girl Scout projects, all of that. And the number one thing that you can do as an individual is be prepared yourself. Make sure that your family and your home is all squared away for a disaster so that you can go to work and not have to worry about your loved ones in your home, not become an additional burden on the community. Coming soon, another amazing team of mostly nurses, not everyone's a nurse, but most of us are nurses. We are doing a systematic review at the Cochrane Library evaluating the effectiveness of household emergency preparedness interventions in the general community dwelling population. We just concluded data extraction and we started data analysis. Spoiler alert, the interventions do improve disaster knowledge, actions, and behaviors, but we still don't know if it improves survivability. If you want to stay in touch with me, you can Google me on ResearchGate or just put a search for me on ResearchGate on LinkedIn and Twitter. My references, and that's it for that. That's me. I'll take questions now. Sorry, I tried to go really fast for you guys.
Thank you so much. That was such a wonderful presentation. We are at time. I am going to stop the recording, but if anyone wants to stay